Hi, Professor E. Can you hear me? Oh,
yes, hello.
your house is very beautiful.
Really?
Okay, to begin this seminar, we welcome some new member, some advisor, a very senior advisor, and I would like to introduce my professor first. Can you introduce something about yourself, Professor E? I just want to you say hello with everyone.
Hi, yes. Hello, everyone. I'm working at now Binmek Hospital in Hanoi. So I'm head of the Department of Oncology and Hematology. And Dr. Chub is very excellent doctor. So he's helping me a lot. And I'm very happy to join this group. And maybe I hope I can learn from you and share our experience
Oh.
to care our patients more. Thank you.
Thank you, Professor. Today, I also would like to welcome Mr. Wu. He is a PD student in the US. Can you introduce a little bit about yourself, Mr. Wu?
Thanks, Brooke, for inviting me to join the club. I'm very happy. My name is Vu. I'm currently a third-year student, PhD student in Dr. Emery Bresnik lab. We are working on the hemochromatosis, and my project is involving the innate immunity, especially toll-like receptors, and interferon gamma signaling in hematopoietic and stem and progenitor cells.
Did you born in Vietnam or US?
I was born in Vietnam, and I came to the US when I was around 20, and then I did my undergrad in the US. But before moving to the US, I was in medical school, Thành phố Hồ Chí Minh, for 2 years. But then I changed my major to bioengineering.
Thank you so much, and I hope that you. I really looking for your contribution to our group and in the future for Vietnam as well. Okay, let's move to Dr. Thu. Could you say something about yourself?
Please turn on mic.
Dr. Thu, can you please turn on your...
Yep. Sorry, it's not on. Yes. Hi everyone. My name is Thu. So I graduated from the same medical school that Dr. Vũ went to, University of Medicine of Ho Chi Minh City, and I graduated in 2016 and came to Australia in 2017, where I did my master degree in laboratory medicine. And currently, I'm working as a medical scientist in a hospital in Melbourne, Australia. So my basic task every day is to analyze tests and blood tests and make sure that it's the correct result for the patient, and reviewing morphology, transfusion, maybe investigate transfusion, antibodies and stuff like that, and biochemistry as well.
Thank you, and welcome you too. I'm regret that there are many members cannot attend today because they are busy schedule. Today, firstly you're taking time for your busy schedule to join us today, and we hope that you will learn a lot today. Now let's move with our speaker today, Phú and Vấn. Phú and Thư, right? Can you let's introduce a little bit about yourself first, and start with your presentation.
Best regard to Professor Yi, Dr. Thư, Dr. Wu, and Dr. Trúc, and everyone participating in our presentation today. I'm Thư. I'm 4-year medical student at Cần Thơ University of Medicine and Pharmacy. And Phú, you introduce yourself.
Thank you, Thư. Good morning, everyone. I'm the 4-year medical student in Chợ University, Medicine Faculty. Thank you for your attending our present today. Thank you, everyone.
Our group contain mainly a medical student in Vietnam, and we aim to improve the knowledge and clinical skill of the medical staff of Vietnam. So the reason why I try to invite the expert from the four corners of the world. Our topic today is the hemochromatosis, and Mr. Fu will interview and explain the reason why he chose this topic, because we Professor and me have the a very interesting hemochromatosis case and case report with Fu as well, and this is the reason why he chose this topic. Okay, let's start with your presentation. Phú, let's move.
The first is Thư.
Thư first. Okay.
Because my English is not really good and I'm still trying to improve, so I hope everyone will understand. Thank you. Firstly, I would like to summarize the iron metabolism of iron in the body. There are two types of iron from the food we eat, heme and non-heme. Heme will be transported into enterocyte through the heme transporter. In contrast, non-heme it means iron-rich blood will be converted to iron to blood by step to SDR2 or cytochrome, and then it's transported to enterocyte through DMT1 or ZIP14 receptor. And in order to get out of the cells, iron must be converted to iron to blood by hephaestin, and which is then transported through the ferroportin transporter. Now let's take note about hepcidin and TFR1. I will talk about it later. There are 5 parts of our content. I will introduce to you guys about from 1 to 4, and 4 will introduce to you guys the last part. Okay, the first the introduction. Hemorrhamatosis is a metabolic disorder where the body absorbs too much iron from the food we eat. Well, hemorrhamatosis has 2 types. They are primary or secondary. And today I will introduce to you guys about primary hemorrhamatosis. Primary hemorrhamatosis is also sometimes hereditary hemochromatosis. So I'm sure you can guess that is caused by a gene mutation, right? Here we have two questions. The first question is what is hereditary hemochromatosis, and the second question is what is HFE gene? Let's begin with the first question. What is hereditary hemochromatosis? Hereditary hemochromatosis is an inherited iron overload disorder caused by excessive and dysregulated intestinal iron absorption that is mediated at the level of the duodenal enterocytes, and is the most single gene disorder in white northern European descent. It's also the most commonly due to mutation in the hereditary hemochromatosis gene. It's also called HFE, which is an autosomal recessive disorder. However, not all individuals with HFE mutation develop iron overload. Evaluation and diagnosis of hereditary hemochromatosis requires interaction of genetic information with other markers of tissue iron deposition such as MRIs continue to be refined. The individual may be referred to non-expressing homozygous or C282Y genotypes without iron overload. Continue with the second question. What is HFE gene? The HFE gene is located on short arm chromosome 6 at location 6p22.2. You can see this it provides instruction for reducing protein. The protein encoded by this gene is membrane protein that is similar to MHC class 1 proteins, and it's thought that this protein functions to regulate circulating iron uptake by regulating the interaction of transferrin receptor with transferrin. The HFE protein interacts with other proteins in the cell surface to detect amount of iron in the body. When the HFE protein bound to transferrin receptor, the receptor cannot bind to transferrin, and in iron cannot enter the liver cell. So it is likely that HFE protein regulate iron level in the liver cells by preventing transferrin binding to transferrin receptor 1. And the HFE protein regulates the production of a protein called hepcidin. Hepcidin is produced by the liver, and it determines how much iron is absorbed from the diet and released from storage sites in the body. Transferrin binding to the transferrin receptor 1 may free HFE to bind to transferrin receptor 2, which may activate the signaling pathway to transduction the hepcidin. The HFE protein is found on the surface of cells, primarily liver, intestinal cells, and on the immune system cells. The next is molecular pathogenesis. Mutation in the HFE gene are seen in the vast majority of individuals with hereditary hemochromatosis. There are two common HFE mutations are observed. They are C282Y and S63D. about C282 wise guanine chain to adenine as nucleotide 845 in the HFE genes. That's called substitution of cysteine for tyrosine as amino acids 282, and about the S63D change cytosine to guanine as nucleotide 187 in the HFE genes. That's called substitution histidine to aspartic acid and amino acid 63, and the former being more common and more associated with clinical disease. In contrast, the prevalence of C282 was extremely low in non-whites, although heterozygosity for S63D were found in 8% of ASEANs. You can see the table about the genetic cause of hemorrhamatosis and mutation in genes that encode other iron regulatory protein have been described less commonly, and the evolution for hemoglobin or hepcidin, transferring receptor 2 and ferroportin 1. Hereditary hemochromatosis, also refer type 1 hemochromatosis to distinguish it from other forms of genetic hemochromatosis. About the hemoglobin, it's a complete penetrance and early age of overlap. About the transferrin receptor 2, it's a rare condition described in case report. It's clinical similar to lexical hereditary hemochromatosis, but onset in young adults. And about ferroportin 1, the clinical condition is MAC injury in reticular endothelial iron, less hepatic iron. Not all individuals with the SFE mutation develop iron overload and clinical. So other genetic and environmental factors, as well as other medical conditions, dietary iron intake and blood loss likely play a role in the manifestation of clinically significant for the iron burden. For those who are affected, lexic hereditary hemochromatosis generally doesn't become clinically manifest until later in adults when significant total body iron accumulation has occurred. Iron accumulates in the liver, heart, pituitary gland, pancreas, and other tissue. Organ and tissue damage occurs by incompletely understood mechanism that may include oxygen-free radicals. And I would like to talk about the fashion reaction about free radicals. You can see iron 2 plus are oxidized by hydrogen basis, producing iron 3 plus, and the hydroxide radical and hydroxide ion. Now, iron 3 plus can be reduced back iron 2 plus and peroxide radical and a proton, and then the cycle repeats, creating this like endless loop of free radical generation. So over time, on the deposits of iron slowly damage the cell in the various organs. Normally, we actually lose a small amount of iron every day, about 1 milligram. Some in the sweat some in the septic skin cells, and some in the septic cell in the gastrointestinal tract. Most of us, through the diet, take in from 10 to 20 milligrams of iron every day and absorb about 10% of that. People with hereditary hemochromatosis, iron absorption is as high as from 2 to 4 milligrams per day, and patients generally become symptomatic when organ iron deposition have been ongoing for decades and total body accumulation is as high as 20 grams. A male who is homozygous for the SFEC282Y mutation will absorb from 2 to 4 milligrams of iron per day. It's rather than the 1 milligram per day needed to balance iron losses. And the woman homozygous for the SFEC282Y mutation who absorb 4 milligrams per day of iron and have regular menstrual blood loss will only retain 2 milligrams of iron per day more than needed for iron balance. The next is clinical manifestation. Patients with hereditary hemochromatosis often presented with symptoms attributable to high level of tissue iron depositions. The severity of presentation depends on the extent of iron overload, and there are about 13% of hereditary hemochromatosis patients refer to a tertiary gastroenterology retic were documented to have cirrhosis. In one study, about 2% refer to a blood center retics. The first clinical symptom is systemic symptom. The patient is fatigue, pain, and non-specific symptom. Overload in iron overload in the liver can make hepatomegaly, increase hepatic transaminase, cirrhosis, and hepatocellular cancer. Excess alcohol intake is a major risk factor for the development of liver disease in the patient with hereditary hemochromatosis, and iron overload potentiates the development of alcoholic liver disease. And case report and small series have suggested that hereditary hemochromatosis induced iron overload also appears to potentiate hepatic fibrosis in individuals with HCV infection. In the meta-analysis of observational study from 20 and 16 that include nearly 6,000 cases of hereditary hemochromatosis and nearly 15,000 controls. Their C282Y homozygous had an increased risk of non-alcoholic fatty liver disease and HCC but not cirrhosis. And iron deposition in the hepatocyte of individual with hereditary hemochromatosis is not inflammatory. Thus, hepatic fibrosis can sometimes occur without increase in serum transaminase. Iron overload at cardiac can make a dilated cardiomyopathy, diastolic diffusion, and heart failure. Also, condition disturbance and sudden cardiac death. Pituitary iron deposition can cause pituitarism with reduced production of trophic hormone for several endocrine organs, leading to secondary hypogonadism or hypothyroidism. And pancreatic iron overload can lead to the PT mellitus. You can see the picture of the patient with from diabetes, and this is the normal, the hand of normal, and this hand is of the run diabetes hereditary hemorrhagosis patient. With central nervous symptom, homozygosis for the SFES63, variant appear to associated with an increased risk of myostrophic lateral sclerosis, and you can see this is the clinical about myostrophic lateral sclerosis. Properties iron overload can make the patient aphrasitis, and the mechanism may include a combination of iron deposition in joints with endocrine complication of pituitary iron overload, leading to reduced bone density. You can see sclerosis, small zone space narrowing, we can see on the X-ray. Skin hyperpigmentation reflects a combination of iron deposition and melanin. The lactic triad of cirrhosis, GM, and skin pigmentation occur late in the disease. Patients with iron overload, including those with hereditary hemochromatosis, are at risk for a number of infections with bacteria whose virulence is increased in the region of excess iron. They are referred to as siderophilus bacteria. They are Yersinia enterolytica or Virio bonificus. An overload can make a HCG associated hepatic iron overload confer an increased risk of hepatocellular cancer and possibly other liver tumors such as cholangiocarcinoma. A database study that evaluated outcome in over 50,000 individuals who has HFE genes, who has HFE gene genetic stating found a 10-fold increased risk of liver cancer in C282Y homozygous. Hereditary hemochromatosis may be suspected in individuals with any of following. They are explain fatigue, clinical signs or symptoms suggestive of iron overload, laboratory test result that may be associated with SS, such as unexplained liver function, high serum ferritin or TSAT, high TSAT. About the liver function test, liver function tests such as transaminase, bilirubin, alkaline phosphatase, are appropriate in any individual with suspected hereditary hemochromatosis. Elevated transaminase typically signifies liver injury, but they are not specific for hereditary hemochromatosis. MRI non-invasive assessment of iron burden in the liver or heart using generally doesn't offer any clinically helpful information and is not routinely indicated. And liver biopsy is not required for the diagnosis of hereditary hemochromatosis. But we generally reserve liver biopsies for the following situation in which histologic assessment would be helpful in the management. There are individuals with evidence of iron overload for whom SFE mutation testing is negative, or individuals with possible hepatic fibrosis or cirrhosis, or individuals for whom another cause of liver disease is suspected, such as excess alcohol, or NAFLD, or hepatitis C, for whom other therapy price may be appropriate. And this is the histological figures describe liver biopsy. You can see this iron overload, iron loading of hepatic parenchymal cells. To sum up, assessment of iron overload is such as serum ferritin or serum iron and percentage situation of transferrin or serum non-transferrin bound iron, or liver biopsy or liver CT scan or MRI or cardiac MRIs. About assessment of tissue damage caused by iron overload, such as cardiac, you can do clinical chest X-rays, ECG with a 24 hours monitor. About liver, you can do liver function test, liver biopsies, CT scan or MRI, fibroscan. About endocrine, you can do clinical examination, pituitary gonadotropin release test, thyroid, parathyroid. The last slide is differential diagnosis. There are thalassemia, transfusion iron overload, other cause of liver disease, heart failure, neuropathies, and other conditions with high ferritin. About thalassemia, not unlike hereditary hemochromatosis, individuals with thalassemia generally have anemia and abnormalities of the red blood cells, and transfusion iron overload. Unlike hereditary hemochromatosis, they have a history of multiple transfusion. Liver disease, unlike hereditary hemochromatosis, they do not cause high TSAT or evidence of excess hepatic iron deposition. About the other cause of heart failure, is not cause high TSAT or evidence of cardiac iron overload. About other cause of neuropathies, is not cause of high TSAT, and the radiologic pattern may differ. And the last other condition with high ferritin, unlike hereditary hemochromatosis, they do not have biallelic SFE mutation or evidence of tissue iron overload. That's all about my presentation, and now Phú will introduce you guys the next part.
Okay. Thank you to okay. Okay. Can you hear me?
Yes.
Next, we will discuss the spotlight of the paper Hemochromatosis, the new blood donor published in American Society of Hematology journal in 2010. I have attached the link of the paper on the book Phlebotomy and its benefits. First, I will go over treatment for iron overload caused by hemochromatosis. Okay. As you can see in this table, we have phlebotomy. I will talk about it later. Erythrocytosis, the peroxamine chelation, and the fluoride syrup. This one is on the next slide. On the characteristics of this method are clearly given in this table. Okay. Most of from my point of view, most of the medical facility in Vietnam we often see the doctor using fluoride syrup chelation therapy. It's good chelation of heavy iron, but not always effective. Especially for patients with iron-induced cardiomyopathy. For phlebotomy therapy has been mainstay of treatment for hemochromatosis patients for higher 60 years. The phlebotomy procedure is illustrated in this picture. You can see it's simple, just draw blood down of the vein, a single 500 milliliter unit of the blood contain approximately 220 to 240 kilograms of iron, depending on the donor hemoglobin. Drop in donor hemoglobin stimulate erythropoiesis and mobilize iron from parenchymal storage side into the bone marrow, where the used to make more red blood cells. In symptomatic patients, phlebotomy can reverse fatigue and skin pigmentation, and in some cases reverse hepatitis fibrosis. There are no randomized trials in efficacy of phlebotomy in hemochromatosis. However, serial phlebotomy therapy lower ferritin level and reduce body acid iron, and when they initiated before the development of cirrhosis or diabetes, significantly reduce obesity and mortality in hemochromatosis. As you can see in this table, symptom patient phlebotomy can reduce fatigue and skin pigmentation, and in some cases, however, phlebotomy in ameliorating the hypogonadism and cirrhosis of hereditary hemochromatosis, and cannot reverse diabetes. Okay. There is widespread consensus to initiate phlebotomy therapy in outpatient with ferritin level higher 1,000 because level in this range are strongly associated with an organ damage. Indication for studying Alex over for hereditary hemochromatosis patient with minor elevation in protein ranging from 200 to 600 microgram per liter, particularly if they have minimal or no symptoms referable to hemochromatosis. Such a patient may not develop progressive disease and may not experience further increase in protein with time. However, because phlebotomy is safe, inexpensive, accessible, and it may even provide collateral benefit to the other. Blood donation treatment EU initiated. The author recommend initiating phlebotomy therapy for all the 200A2Y homozygote with protein level above the reference range. So the target of phlebotomy is protein level between 50 and 100 microgram per liter, a value that ensure the depletion of acid iron, but the subject with iron reverse iron depletion, but not iron deficiency is the goal. Iron deficiency is surprisingly easy to achieve and should be avoided. The base of initial phlebotomy is dependent on starting protein level. As you can see in this figure 1, for protein higher 1000 microgram per liter, phlebotomy is generally initiated quickly for level 500 to 999 microgram per liter is bi-weekly for level up 200 to 499 every 4 to 8 weeks. The pace may be slow when the protein approach the targeted range of 50 to 100 microgram per liter. Serum protein is usually monitored every 2 to 4 phlebotomy sessions, depending on the phase of treatment, until it's the lower 200 microgram per liter, and every 1 to 2 donation until it falls below 100 microgram per liter. Minimal hemoglobin present with phlebotomy should be 12.5 gram per liter. In the cohort of 130 subjects with variant SFE allele referred to a blood center for management. 76% make eligibility criteria of allogenic blood donation, and 55% had the previous blood donor before being made aware of diagnosis. Recognize that hemochromatosis subject could constitute set shock of the blood for transfusion, the US food and blood administration in 2001, ICU using allowing blood center to submit variant to viral code to allow blood from hemochromatosis donor to be used for transfusion to ensure adequate safeguard around this process. Variant must include row region that donor otherwise on allogenic donor repair. Phlebotomy is provide free of charge to all the hemochromatosis subjects who come to the blood center in need incentive for hemochromatosis donors to be untruthful in responding to the standard health history screening questions are minimized. Medical prescription for phlebotomy therapy, including frequency and hemoglobin threshold, is provided by donor, physician, and abbreviated physical examination is performed at each visit if the donor donate more often than every 8 weeks. As you can see in this table, it estimates that routine referral of hemochromatosis subject to blood center for phlebotomy care could be supplement the U.S. Blood supply an additional 1.3 million red blood cell units per year. Mostly have to avoid corroded red blood cell shortage, avoid wasted of the state unit, and prevent the top care. Treatment of hemochromatosis in the donor center may outstep to ensure that minimal acceptable hemoglobin level versus with the donation of therefore below 12.5 gram per deciliter is legal limit for blood donation. Use of the donor hemoglobin threshold after criteria for phlebotomy may thus help to prevent the overly aggressive of iron depletion that is sometimes seen in clinical practice. In smaller hospital, blood bank with active hemochromatosis human and management program, hemochromatosis donation can contribute substantially to consolidate blood supply, constituting 10% to 40% of available red blood cell eventually in the center without active recruitment. Only 0.5% of our blood donation will be deprived of hemolytic subject. One additional advantage of hemolytic treatment in blood center is that phlebotomy can accomplish with you of double red blood cell apheresis by during double red blood cell apheresis procedure to pack red blood cell units are collected from single donor and isolated manner with solid infusion. Replace the red blood cell volume loss. Donor must have a slightly higher qualified hemoglobin of 13.5 grams per deciliter, but this approach may reduce frequency of visit by the head and still accomplished in the same page of our remote. A routine referral of hemochromatosis subject to placenta for phlebotomy care could be factored into current debate on the targeted solution screening for hemochromatosis. Part of the debate involved asset costs of diagnosing, monitoring, and treating the disorder with unintended livelihood causing clinical disease in the future. Economic model population screening for hemochromatosis has suggested that gender screening would be cost effective only if at least 20% of subjects develop life-threatening condition, like threatening complication as in lower 5% to 10% of hemochromatosis subjects developing process subjects as small and large are treated with a frequency of at least 20%. That's what conclusion of phlebotomy theory next year care response. Wait a minute. So this is a case study. Okay. So this is a case study about hereditary hemochromatosis. The idea to stop this case resistant patient came from a group who immediately upon 22 to fly carry of the patient with a mutation in the SSE gene. I will show you this case right now. In this case, we have a 33-year-old Vietnamese male with a 2-year history of high protein level, approximately 2,000 nanogram per milliliter, associated with hyperpigmentation. As you can see in this picture, the patient's skin this is patient skin darker than doctor skin. After his skin pigmentation, he had jaundice, fatty, just reduced and upset like unexplained weight loss about he lost about 10 kilograms. Honest, for more than 20 years, his medical history was significant for insulin-dependent diabetes and hepatitis C was diagnosed 20 years later. 6 years ago, the patient had an episode of the protein level above 1,000 nanogram per milliliter, and was checked. He has a 75 year history of smoking, and he is a substitute drinker. His medication include diphenoxylate 250 2 tab PO every hour in day for four tablets in day, and insulin basal 24 unit, blood cell unit, 60 unit total. This is family tree. You can see he has a brother. It it's not able in family tree is that both his brother and son spirit iron overload, which is who have creatine level up 7,000 545 nanogram per milliliter and 730 732 nanogram per liter per milliliter, nanogram per milliliter. Especially, he also had a sister who had thyroid cancer. As you can see, he's black way. It is the family tree. This is a laboratory finding. Currently, he currently testing blood glucose level were controlled on overrate from 8 to 11 millimole per liter per day. The highest level is 12 millimole per liter. So you can see this is laboratory, and this is sorry, my laptop is crazy. So sorry. And this is iron channel. You can see in the patient creatinine is very high, and also the patient for the serum creatinine is very high. But hemoglobin were normal in the patient and in the patient form. Imagine non-inhaled MRI abdominal level iron concentration approximately 2.25. The head of liver is 18.7 centimeter. The signal intensity of the level of parenchyma is uniform. The sign of non-bladder is normal. No dilation in the biliary system. Abdominal ultrasound, the level of parenchyma has a slight increase in the endogenous echo geneticity. They calcification of renal parenchyma in the left kidney. Spot line in indicate the genetic step for hemolytic. So you can see SFE homozygote receiving phenotype hemochromatosis, and especially this variant has not been reported for Linva. It's time to discussion. What do you think about this case? Thank you for attending our presentation.
Okay. Thank you, Fu and Tu, for an interesting talk. Even though my internet connection is interrupted, so I cannot hear fully from your presentation. But anyway, I can understand them. I think there is many points we can pick up from this lesson, and also have many points we can improve the quality of the presentation. I'm waiting for question from attendees, but firstly, I want to have some comment from our advisor. Please give your some opinion to have them improve their lesson. Professor, can you give some comment?
Yes, this is very great presentation. So yes, the first presenter talked about the MRI. So recently, there are many techniques to evaluate the iron status in liver. And recently, IL-2 star technique of the MRI can detect iron accumulation in the liver. This is very useful clinical way to evaluate the iron accumulation in the liver. But in terms of clinician, to approach of hyperferritinemia patient is more important to the primary physician to detect hemochromatosis patient. Actually, our case shows many clinical features of hemochromatosis, but actually to confirm the hereditary hemochromatosis is a challenging issue for primary physician because genetic analysis is not available in most clinical setting, but fortunately we could do genetic analysis for this patient, and we could find very rare, maybe first among the world, of the specific genetic mutation occurred in HFE protein. This is very interesting case.
Thank you. Thank you, Professor. Fu, please turn off your microphone. I hope that in the next time, please prepare more better background, because Tu and Fu have a very poor environment. We have a lot of the bias sound, so very difficult for us to focus on your lesson. Please give more question and comment for us. Is there any opinion for us?
Actually,
okay.
Yeah, another point is that yes, in the textbook, many cases are saying that the clinician can detect and find the hemochromatosis patients when they present some symptoms or sign of the organ damage. But actually, in my opinion, I don't know why, but in Vietnam, many people checked their regular health screening test in many other hospitals, and the hospitals performed ferritin level in their setting of the health checking. So many people realize that their ferritin level is very high, and then they visit to the primary physician to hear why their ferritin level is so high. But actually, there are a lot of reasons of hyperferritinemia, because ferritin is elevated not only hemochromatosis, but also other many kinds of inflammatory disease, because ferritin is the marker of the inflammation. So we doctors are frequently confused that why ferritin is high, and to make a diagnosis with hemochromatosis, especially hereditary hemochromatosis, is very difficult because the genetic test is not available, and also the usually primary physician hardly think the reason of the hypoferritemia is hereditary hemochromatosis. So many cases, physicians perform a lot of tests to find the cause of hyperferritinemia, especially in terms of inflammation, including cancer or other hematologic disease or other conditions which have inflammation in the body. So unnecessary tests, a lot of unnecessary tests can be performed to the patient. So I think for clinical physicians must make a reasonable way to evaluate the cause of hyperferritinemia. So actually in this patient, our case, he wandered a lot of hospitals to find the cause of hyperferritinemia. So he could a lot of time, a lot of money to find the cause of his condition. So after many years, he finally visited us, and luckily he could find the cause of hyperferritinemia as hereditary hemochromatosis. So we can get some lessons from this case, that how to make an accurate diagnosis as soon as possible and manage it properly.
Thank you so much. I think in case of hyperferritinemia, even though we made hyperferritinemia into many circumstances, but as Fu mentioned, there is one important marker to thinking about the hereditary hemochromatosis is the transferrin saturation. So usually in the chronic inflammation, even though ferritin level increase a lot, but in this case, most of the case, transferrin saturation will be decreased or just in the normal range. So if the patient have transferrin saturation increase combined with the ferritin level as well, I think the indicator we should thinking more about the iron overload for our patient. Dr. Tu, please give your opinion.
Yes, thanks Dr. Yi and Dr. Trúc for your opinion. I think it's a very interesting topic to discuss, because previously in the slide I can see that I think is the Trúc or Tu, Fu or Tu mentioned this one. So they say that in America, the screening for hemochromatosis in patients with high ferritin is not economic if beneficial until the patient have some life-threatening condition. So that is my question. So, and about the practice maybe in Vietnam and maybe in the US, like when will you decide that you should refer a patient for specialized test to test for hemochromatosis, because apparently, like, even if it's a little bit higher than the normal range, it still doesn't really necessary to do all the tests for the patient.
Our speaker can give your answer.
From my point of view, I'm just a medical student. I'm not in clinical practice in Turkey, but I think in Vietnam, most of medical facilities not they just calculation by oral medication, and sometimes in secondary care in a specialist, they perform genetic test for hereditary hemochromatosis, and I don't see that's my idea. I
Yeah.
That's all. That's my
Okay. Yes, I understand. It's a bit hard for you, but Dr. Chu will know more. Like, do we have any guideline how to approach a patient with high level of ferritin in Vietnam, Dr. Chu? Do you think we have any of those?
In
Ah,
in my opinion, as you know that we usually saw the hyperferritinemia in two common ways. Firstly, in the anemia patient. With anemia patient have the hyperferritinemia, this is just user case. Frequently, we met the many anemic patients in Vietnam have the hyperferritinemia. Usually, most of them had a condition of the chronic hemolysis, like in some hemoglobinopathy, in thalassemia, or other kinds of hemoglobinopathic patient. We don't need to worry about the hereditary hemochromatosis. This is just the in nature. If the patient have anemia, 100% the patient have the hyperferritinemia. If the patient don't have the loss bleeding loss, if the patient don't have any source of the bleeding, we can think that the hyperferritin level was caused by hemolysis as well. But in other circumstances, like the person don't have the anemia, and now we found incidentally found hyperferritinemia, we need to do some further workup to make a correct diagnosis, including besides ferritin, we should do at least including serum iron, transferrin level, and TIBC, total iron binding capacity, and transferrin saturation as well, because we need to differentiate the true major diagnosis in case of hyperferritinemia in this case. Firstly, ACD. ACD, that means anemia of chronic disease, and in the other case, either primary hemochromatosis. In ACD, in most of the case of chronic inflammation, it can cause the hyperferritinemia. But whenever our body sense of the iron overload in the body, they will regulate it by the way to down-regulate the production of transferrin. So you can see that the transferrin level will be low, and they also in chronic inflammation, they block the release the iron from inside the cell to outside, so serum iron will be low. That's the reason why in ACD the ratio between the serum iron and total iron will be transferrin level will be low. That means that transferrin saturation will be normal or just a little changing. But in case of the primary iron overload, you can see that because the patient, our body cannot cannot exclude the iron out of the body, so iron accumulation increase over time, years by year. So serum iron and transferrin saturation as well will be increased a lot. And if you want to make clear, you can see again with our case. But I don't know why Fu don't show the transferrin saturation for our case. But you can see in the serum irons as well. Not many case, not many cause can cause the increase in the serum iron and transferrin saturation as well. So if the patient have the elevated transferrin saturation, I think this is the starting point to do something more to think about the hereditary hemochromatosis. And the guideline also show that.
Yes, I'm understand. Thank you.
And I just have another question. Do we do hepcidin test in Vietnam? Because I know that like hepcidin can be tested to see the level of hepcidin that can add up to the differential diagnosis from iron overload and iron deficit and anemia of chronic disease, like you just say.
Even though we don't have the hepcidin level testing in Vietnam, but in VMed we can do that because Professor have been connect with the Korea laboratory company, and whenever we need to do some more complicated tests, we can send the sample to Korean company lab.
Yep. Thank you, Dr. Chu. Thank you, Dr. Yi.
Very regret because Mr. Wu is busy now. I cannot see the message. Let me see.
Yeah. And thank you for our presenters. You guys did a very good job. I think that when I was in 4th year of medical school, I wouldn't be able to do something similar. So very courage of you, and you must have put a lot of effort into this one, a lot of research.
And thank you. I think language barrier is a big barrier for Vietnamese students as well. And as you also talked before that, we need to improve language ability for Vietnamese medical staff first. This is maybe the best chance for us to approach more the up to the minute knowledge of the medicine. Before we can close this topic, I want to some student give your opinion about the feeling, and don't need to talk more detail about the knowledge because you just student, medical student, you maybe cannot understand fully about very difficult knowledge. So please say something about your feeling about this topic. Who can help me? Phone?
Yes, I'm very pleased to perform this presentation. I'm feeling this I feel hot, and but I'm opportunity work with Dr. Chúc and Dr. Chúc is our mentor for this presentation, and I think for that we have this presentation successfully. Thank you. What about you, Thu? What?
I'm so pleased to meet Dr. Yi, Dr. Trúc, and Dr. Thư. I hope to learn about Roma, and I will try my best. Thank you.
Maybe you feel many pressure. Okay, let's
Yeah,
talk.
it's
Excuse
certainly
me,
a big.
can I have a
It's a big
question?
topic.
Let's go ahead, Ben.
I have a question about in the title of this plus event here. This is a new plus donor, and I consider about is all patient with a with a hereditary hemochromatosis without any underlying with transmit through the blood, such as SIV or uh, uh, SIV. So if they don't have any underlying condition, their blood is completely safe and become the donor. And in Vietnam, is there any this patient will be a donor, or they just phlebotomy and remove this blood? That's all. That's all.
Phu, do you want to talk with this?
Sorry, can you repeat the table of your question?
I mean, then I will answer again. I consider that with a patient with hereditary hemochromatosis without any underlying conditions such as SIV or HCV or SBV, if they become a blood donor and their blood is completely safe for any patient. And in Vietnam here, is there any patient with hereditary hemochromatosis can be the blood donor, and or they just be remove the blood and don't use that blood. That's all about my question.
I think I don't see any model blood donor from hereditary hemochromatosis in Vietnam. This patient in this case, I present a reason in he see no blood transfusion and phlebotomy in therapy in his therapy. So I have the patient hereditary hemolysis patient in Vietnam can apply the model blood donor like paper. So I hope so, but I don't see any. From my point of view, I don't see any. I'm just a medical student for the because I don't see what from my okay. Do you satisfy my answer?
Actually, I think I was a little bit surprised that America had some registry or data for donation from hemochromatosis patients, because I think the instance of hereditary hemochromatosis is very frequent in Caucasian, but very rare in Asian, I think so. So frankly, I never seen the hereditary hemochromatosis patients when I was in Korea. So maybe in Vietnam, this disease is very rare. So we don't have any data for donation from that kind of patients. Yes, maybe nobody can answer about your question in Vietnamese.
And I also want to comment that according to the regulation in Vietnam from the Ministry of Health, just only few centers can collect the blood from donor to using for blood donor as well. So even in your hospital want to take blood from patient and use that as the blood donor products, but we cannot do that according to regulation. So very difficult. And in Vietnam, I believe that not many patients will make the correct diagnosis. And when someone want to give want to donate their blood, they just check with the hemoglobin level. If nothing special, they can give their blood donating without any considering about the diagnosis. So your question may be not clear to answer at this time. I have a question to Dr. Tu, because you know that this is the new mutation we found in the HFE gene in hereditary hemochromatosis. There are only two kinds of mutation we record in literature, including C2A2Y and H63D. But in this case, we found a new kind of variant. We don't know well about the relationship, the cause and consequence relationship in this case, but clinical feature so that it truly the hereditary chromatosis. So we want to demonstrate this variant is truly the causative mutation for this case. For that, we must to use the animal model to demonstrate the mechanism of this new variant, but maybe it's very difficult to do this in Vietnam. So how about in your lab? Can we cooperate with your lab to make demonstrate this kind of mutation?
Okay, so actually I don't work in the genomic department, so I'm not really sure like how they process it. So my experience with hemochromatosis in the lab, I can see that in Australia, so the vivisection, I'm not sure about in Vietnam, but in Australia, the vivisection is quite a simple process for patients. They can come to the collection room. The phlebotomist can help them do the vivisection. They don't even need to see the doctors or the nurses. They have a request from the doctor. They go straight there and they have the vivisection. And we just discussed about the transfusion like potential, but in Australia I don't see that they have any clear guideline about potential transfusion potential like America as well. Like so, when I saw that in the presentation, it's something interesting as well. Yeah, they can be very good potential transfusion donors. Yeah, it's a pity when I see that the blood has to be discarded, and some people actually need the blood. And for the genomics, yeah, you say that we have two like most common genes, and you want to prove that the one that you found is actually the one that caused the disease. Is it correct? I think that's a kind of a pretty lengthy process, and it's probably not done in a diagnostic lab. Where I work is a diagnostics lab. It's like that process needs to be done in a research lab, maybe institute or university-based lab where they have more like people and more equipment to perform those experiments. And it can be a PhD like topic as well. It's gonna take a really long time. It's not very easy, but I think it's possible. But it takes times and efforts and yeah, humans and facilities.
My goal is that I really want to connect a Vietnamese doctor with the foreign expert and in foreign laboratory, because you know in Vietnam, basic science field is in very early time. They just focus mainly on the clinical field, diagnostic field only, but to do more research and can publish the paper without the basic science technology, we cannot make the valuable article. So we have patients, we have data, but we cannot publish because we lack of the quality of data. So I really hope that as a Vietnamese Australian, I hope that you can help us more to can improve our quality of the Vietnamese healthcare system.
Yes, actually, I'm not Vietnamese Australia. I'm still Vietnamese, so I'm just live in Australia, and yeah, that's true. I understand like your I understand your the struggle that doctors, clinicians in Vietnam have. Yeah, I agree that we need to develop a better basic science with research because seems like there is a stereotype in Vietnam. Like when you have a very smart kids, you want them to become doctors, become yeah, most of the time it will be doctor, but no, actually in the field of medicine, it's not only doctors, like it's also scientists who like, and also people who do research behind the field that actually develop this knowledge. Doctor is very important because, but their main major is kind of apply the knowledge and to communicate with patient, apply the knowledge to treat the patient. And yeah, I agree that we need in Vietnam we need a better like behind the scene scientists who actually have developed this knowledge and like together with the doctor we can develop we can improve the patient care. And yeah, we do. I think that uh, I can see that many Vietnamese, when they come overseas, they become a very good researcher. I think we just need a good system to encourage people to be more into to do research, do what they really like, not just and have the other people and maybe the policymaker understand that like there is a side of medicine that also need to be developed, not only like just training more doctors, more nurses.
I think Dr. Tu can be a good mentor for the young Vietnamese doctors who wants to go abroad and to be a doctor in foreign countries.
No.
Actually, Dr. Yi, I'm not really a doctor in Australia. So I graduated as a doctor in Vietnam, but then I came to Australia and did master in laboratory medicine. So now I'm just working in the lab as a scientist. So it's a multidisciplinary lab. Like when I work in hematology, biochemistry, transfusion, and yet do some morphology. But I think that there is a big difference between what a scientist in the lab do in Australia and in Vietnam because I used to work in the lab in Vietnam and the scientists there they don't involve in a lot of troubleshooting like here. So I think it's also a field that I hope if Vietnam can develop better and have more better scientists in the lab, it can help the clinician a lot and make sure that all the research when we hand it to you guys, it will be correct. Like there's no other interference from analyzer or storage or transport, and then it will be easier for you guys to make a decision for the treatment of the patient.
I want to hear the point of view from the listener, student listener. Hoàng Phúc, can you give, because you don't have, you know that you don't have many chance to talk with many experts, foreign experts. So this is the chance for you to raise your voice to learn more about from them. So let's give your opinion about the lesson and also your willing to talk with you. Hoàng Phúc, can you hear me?
Oh, you are. Yes, I can hear you.
Hmm.
Um, I'm.
Can you give some feedback?
Yes, I want to. Yeah, I want to thank the two presenters today for the very good presentation and which is very informative. And though I don't have any question to pose, I want to The presentation is a good chance for me to update my knowledge in hemochromatosis. And I'm still looking for the official guidelines and protocol for a for a kind of more general picture of how to diagnose and how to treat this disorder.
Thank you. Is there any comment?
Dr. Trúc, actually, just want to have some maybe suggestion because this is a weak file. I haven't been like watched like participated in any of the presentation, but I just have some suggestion from my own like experience as it used to be like Vietnamese like international student came to a different countries and present in a different language. And as I was a student as well, I was a master student at that time. So for me, like, I just want to make clear something like what is the actual purpose of this group, like for is it for the audience? So the main audience of the main audience will be medical student. Is that correct?
Right.
Yeah. So I just suggest that maybe the format of the presentation. I'm not sure like the experience, like Dr. Yi experience. Maybe he's been to more overseas presentation than me. I just participated some. So I think the format we can do something to have it like a little bit better. For example, usually here in Australia, the presentation, I think for a long one like this, we can, I think we already cut into different parts, which is good. But I suggest that maybe we can stop every, like, we make the part like maybe in 20 or 30 minutes for each part. And then at the end of each part, we can have a summarize of the part and then we stop a little bit for the audience to participate and ask questions rather than like leave the question for at the very end. Maybe like people will start to lose focus or forget what they want to ask in the first part. And I do suggest that like if on the at the start we have a summarize what we're gonna say in that part, and then we develop that. And before we close the part, we can have a summarize again the main point of that part, and then where people can like start to ask more questions. So it's kind of like help the audience follow the topic better and also participate it better rather than just passive listening.
That's good
Yep,
comment.
that's my experience at when I was a student. So that is the format that we usually have to follow when we present in university in English.
Passive is the most the weak point of the Vietnamese student, as you know. I really want them, even though my English is very terrible, but I just try to talk as much as possible because I think practice is the only way to improve about our not a skill. But very difficult for me to push them to more talkative. So I want to introduce them, connect them with more and more expert, and I hope that in someday I think it takes time, but someday they will change their mind and become more confident on themselves, and they can help other people like I met with them.
Thanks, Dr. Chu. Actually, your English is very good. Like for someone who never travel overseas, my main point is not like the student are being passive. Like my main point is we can change the formats to help them to be more participative. And I'm sure that given chance, like they will like this. This is just a barrier that make them. It's hard for them to follow. So hopefully, if we change the format, we can give them more opportunity to give their ideas, ask more questions, I guess.
In here we also have the America student. I want to give you, even though you are not official medical student, but I think you have the many experience in the presentation. So, me, can you share some experience or some feedback about our lesson today?
Yes. Okay. So I would like to thank you, Fu and To, for the very informative presentation, and I'm really glad that we have all the experts here, so that could so that the expert could give us advice in terms of medical knowledge. And I would say that the presentation, I think I am really interested, and it got me interested in hemochromatosis, and I would like to do more research into this field. And I don't think that I have any question. I just want to say that I'm really glad that I am able to hear this presentation and gain more knowledge.
Before we close, I really hope that Professor can give some guidance for us and make a better presentation in the next term.
Yes, I totally agree with Dr. Tu. Yes, we can reduce the time of presentation, and also we can increase the time to discuss together, ask something, and get feedback from audience. Can motivate more, and also we can, if most of audiences are medical students, we can deal with more common or more easier cases or subjects to make the students improve or have a more interest in that our issues in here.
Yeah, I agree with Dr. Yi as well. That's one of the points that I want to point out as well. I think maybe the depth in this one, thanks for the presenter to go to very depth, to go in deeply information. But if our audience are mainly students, I think we can concentrate on more basic things so that it's easier for the student to follow and understand rather than go a little bit too deep into details and guidelines. And yeah, maybe we can just have I can, if later I can send you some kind of format that we used to use for our presentation in Australia. It's very simple. You start with definition, the diagnosis, definition, how you find it, and the test and the treatment. So maybe start with something small first, so it's easier for students to follow before go deeply into the topic. And yes, I agree with Dr. G that we can do some more common disease, so it's more interesting for the for the students, and they can apply it into their everyday clinical experience.
Thank you so much for your opinion. I will review the topic and let them choose more common disease. In fact, I try to recruit more doctor hematologist in Vietnam, but whenever they know that this is the English program, they don't want to enroll anymore. I am very tough for them. I think so. Even though we present with Vietnamese, it also hard for them because Vietnamese doctor have to work very hard, and it takes time for them take a rest at the weekend. Just only medical students have enough energy to enjoy our activity.
Oh yeah, so that's very impressive of Dr. Yi and you to have enough time to be with us today.
Because your willing is very nice to have student and Vietnamese medical staff as well. Finally, I want to say again, say thank you again to all of you because your contribution to our presentation. I hope that you can continue to attend and give more excellent point for us. And I hope that our student can learn a lot from our college and also our expert as well. Thank you and say goodbye for. Thank you, Professor
Okay.
E, and thank you, Dr. Tu.
Goodbye, everyone.
Goodbye,
Goodbye.
everyone.
Thank you.
Bye.